Greetings again, everybody. We're going to talk in this section about malabsorption, and I could have just as easily called this section steatorrhea, because when you have malabsorption, and we're talking about malabsorption of fat, you're going to get invariably a fatty diarrhea or fat in the stool. So malabsorption, we're talking about malabsorption of fat, and because we don't absorb the fat, we're not going to absorb the fat-soluble vitamins, and those are vitamins A, D, E, and K. And so to a variable degree, you may have vitamin A, D, E, or K deficiency. There are a lot of causes of malabsorption. We're going to talk here about 5 of them. We're going to talk about celiac disease, which is increasing in awareness in the U.S. We're finding more and more patients with celiac disease because we're testing them. So celiac disease is a very important cause. Also chronic pancreatitis. You're going to see this in patients with risk factors. So patients who are chronic alcoholics. Chronic pancreatitis is something that goes hand in hand with that. We'll also talk about tropical screw, and then Whipple's disease, and then cystic fibrosis. This is generally not something we diagnose in adults. Usually this is diagnosed during early childhood, if not infancy. But it's worth talking about anyway because patients who have cystic fibrosis can go into adulthood, and if they're not taking their fat-soluble vitamins as appropriately, or if they're not taking their pancreatic enzymes, which they usually get exogenously, then they can go into a malabsorptive state. So symptomatically, the most prominent symptom of malabsorption is steatorrhea. If they do show vitamin deficiency, they're most likely to show deficiencies of vitamin D and K. So that can lead to hypocalcemia as well as an increased prothrombin time. Typically with vitamin D deficiency and malabsorption, we're not going to see the bone symptoms from that, which would be like osteoporosis, or in children they can have osteomalacia. Usually that requires a lot more significant vitamin D deficiency, but keep in mind that those are signs of vitamin D deficiency. Also, very important, weight loss is a sign of malabsorption. Why? Because if you're not absorbing fat, which remember fat, you get 9 kilocalories per gram, which is more than twice what you get from a gram of carbs or a gram of protein, you're going to be energy deficient. So that can lead to weight loss. Steatorrhea is confirmed with a positive fecal fat test. So that's a pretty easy test to get. You get a stool sample, you run a fecal fat test. That should never come back positive in a normal patient. So if it comes back positive, you've diagnosed the patient with steatorrhea. Another cause of malabsorption, I suppose, but really a cause of steatorrhea, is C. diff diarrhea. So that would be Clostridium difficile infection, which causes that pseudomembrane along the GI tract and the colon, and that's going to also lead to a fat in the diarrhea. That is acute in cause, so typically you won't have weight loss and A, D, E, and K deficiency because this is just something that comes and then it goes. But C. diff diarrhea is something that you will see in the hospital. Patients who are on antibiotics, they develop diarrhea. You should definitely be thinking that anytime a patient who's on antibiotics develops a diarrhea, you should be getting a C. diff toxin assay. Nurses can be really good tools in the hospital, and especially for diagnosing C. diff, because apparently C. diff diarrhea has a very characteristic odor to it. I can't tell the odor of C. diff diarrhea, but then again, I don't spend, physicians will not spend more than 5 minutes, 10 minutes with a patient in their room. So ask the nurse if the patient has diarrhea, do you think it's C. diff? Because a lot, especially the older nurses who have more experience, they know the odor of C. diff diarrhea. So get their insight, but either way, if you have a patient on antibiotics, especially very strong antibiotics, you want to get a C. diff toxin assay, just as a side there. Okay, so let's talk about celiac disease first. Celiac disease is an autoimmune inflammatory response to gliadin. Gliadin is a protein found in wheat and in other grain products. And so autoimmune, meaning that it's going to be a response that's initiated by your own immune system. You're going to create antibodies towards gliadin. And the reason that this is a problem is because those antibodies will also attack your small bowel. And so the fact that it attacks gliadin is not so much a problem. It's the fact that it also will attack your small bowel because for some reason gliadin and a protein that's expressed on your small bowel are similar. So these antibodies will create inflammation, and it damages the small intestinal mucosa, and the small intestinal mucosa is responsible for absorbing fat. So if your small intestinal mucosa is damaged, you can't absorb fat, and that's going to lead to malabsorption. Now remember that the small intestine is also responsible for absorbing iron, and so another way that celiac patients can present, and in fact the most common way for them to present, is with anemia and with pallor. So iron deficiency anemia is a common presentation for patients with celiac disease because their small intestine is damaged to the point where they can't absorb iron. The symptoms are going to be anemic symptoms most commonly. That's the most common way they present. Chronic diarrhea is also another common way of presentation, or the two of them together. Steatorrhea is going to be the type of diarrhea that these patients have. So the way you want to ask the patient is, how do you describe your diarrhea? That sounds like a stupid question, but when you're going through this terrible illness that causes diarrhea, you usually will notice differences. And so having your patient explain them, particularly a patient that doesn't really know how different diarrheas present, if they say, oh, it's oily, well then there you go, probably steatorrhea. Weight loss is another common symptom, and then dermatitis herpetiformis. And this is a common word that you'll see if you read textbooks, but the USMLE is not going to tell you dermatitis herpetiformis because that would be a dead giveaway. It's very highly associated with celiac disease, and they're not going to give you, they're not going to make it that easy for you. So what they will say is small blisters, bulli that express yellow fluid. And so they may also give you a picture. So here's a picture of dermatitis herpetiformis. Dermatitis meaning skin inflammation, herpetiformis meaning form of herpes. It looks just like herpes. They can be big, they can be up to 1 centimeter, the vesicles, and they tend to express yellow fluid. So if you see this ever in a patient, go ahead and poke it and see, make sure you're following safety precautions, but go ahead and try to express some of the fluid out. And if you see yellow fluid coming out of these, that could be what it is, dermatitis herpetiformis. The size can vary from 1 centimeter to very small. So you can see this on the right here is a little smaller. It can happen in any part of the body. And the way you can tell this apart from some of the herpes virus lesions is that it's not going to be on the oral or buccal mucosa. It can be, but it's less likely to happen there. It's not going to be so much common on the genital mucosa or genital area, and it's not going to follow particular dermatomes. So here's some smaller dermatitis herpetiformis lesions. So these ones are much smaller. And this one here on the right is a good one because you can see sort of various blisters and some that have kind of crusted over. So they appear differently in different patients. But what they all have in common is that they're blistery looking lesions, papules that express a yellow fluid. Okay, so autoimmune inflammatory response to gliadin, as we mentioned, the small intestine can't absorb iron. That's why it can present with iron deficiency. It can't absorb fat. That's why it causes steatorrhea. When you are suspecting celiac disease, the best first step is to get serology. And serology is very specific and very sensitive. You're going to get a triumvirate of different panels here. You're going to get an anti-gliadin, an anti-endomysial, and an anti-TTG, which is a tissue transglutaminase, anti-tissue transglutaminase antibodies. All three of these are going to be what you want to get. In real life, you might work for a physician that only likes to get 1 or 2. That might be fine, but as far as USMLE is concerned, all three of these are good. You're going to want all three of these. But any of these are pretty darn specific. So on confirmation, once you know that you've got a positive result for any 3 of these, then you're going to want to get a small bowel biopsy, because a small bowel biopsy is the most sensitive. It's the gold standard way to diagnose celiac disease. And another reason why we want to get a small bowel biopsy is because we want to check for small bowel lymphoma. We want to check those white blood cells that exist in the small bowel mucosa, because some of them could be cancerous. So we want to check for that. But small bowel biopsy is not the best first step, but it is the gold standard for diagnosing celiac disease. And the treatment is just to avoid the precipitant. So avoid wheat products and grain products, and it's just a gluten-free diet. And now that awareness of celiac disease has become more widespread, it's very easy to follow a gluten-free diet. A lot of restaurants are coming out with celiac-friendly foods. There's even a place down the road from where I live that makes gluten-free cupcakes. They're a cupcake store, and they make gluten-free cupcakes. So yeah, lots of different things you can get that are gluten-free, and no excuse to not live a gluten-free lifestyle if you have to. Lots of things available. Okay, so chronic pancreatitis is another cause of malabsorption, but it's for a different reason. So chronic pancreatitis is permanent damage to the pancreas due to repeated insult, most commonly from alcohol, but it could also be idiopathic. Now, whereas with celiac disease, what you had was a malabsorption due to damage of the small intestine mucosa where you absorb the fat. What you have in chronic pancreatitis is a malabsorption because we can't break down the fat. The small intestine can very easily absorb fat, but the problem is you can't break down the fat because the enzyme you need to break the fat down to absorb it is lipase, and lipase comes from the pancreas. And if your pancreas is damaged, as it is in chronic pancreatitis, then you're going to have a hard time secreting lipase and thus breaking down fat, and that will cause a malabsorption. So the symptoms are going to be chronic diarrhea, steatorrhea, weight loss, particularly in a patient with repeated episodes of acute pancreatitis. So when you go on and look at this patient's history, you're going to see that they've been into the ER multiple times for acute pancreatitis. What is acute pancreatitis? It's totally different from chronic pancreatitis. Acute pancreatitis we're not going to talk about in this section, but it's severe dull abdominal pain with vomiting and pancreatic enzyme elevations, particularly in an alcoholic. That's just your stereotypic acute pancreatitis episode. Chronic pancreatitis patients will have had multiple episodes of acute pancreatitis, and these will generally be alcoholic patients, chronic alcoholics. And very rarely will they have anemia. Why? Because, and if they do have anemia, it's not going to be iron deficiency anemia. And the reason why is because they can absorb iron. Their small bowel is perfectly intact, unlike in celiac disease where the small bowel became diseased. In patients with chronic pancreatitis, their small bowel is fine. They just can't break down the fat and thus can't absorb it. So patients with chronic pancreatitis, sometimes they can develop they can have a macrocytic anemia. And the reason why is because patients with chronic pancreatitis sometimes have a hard time absorbing B12, and of course B12 is necessary for red blood cell production. So they can have a macrocytic anemia, and also just in general, alcoholics tend to have low B12 levels. So very rarely is there anemia with chronic pancreatitis, but if there is, it's going to be macrocytic, not the iron deficiency microcytic anemia. And for the USMLE and really for real life, the patient's history is going to be what points to the chronic pancreatitis. There's not really a lot of labs we can do, not really a lot of objective ways we can look at chronic pancreatitis. It's going to be the history of the patient that points to chronic pancreatitis. So generally we can diagnose it on history, but you can get a CT or an abdominal plain film. And in about half of the patients that have chronic pancreatitis, it will show a pancreatic calcification. But the absence of pancreatic calcification does not exclude chronic pancreatitis. So not all patients with chronic pancreatitis will have the calcifications. Amylase and lipase levels are very reliable for acute pancreatitis, but it is absolutely not reliable for chronic pancreatitis. As a matter of fact, the patient will usually have normal or reduced amylase lipase levels. Why? Because the pancreas is worn out. And the treatment for chronic pancreatitis is quite simple. They lack the enzymes necessary to break down fat, so what do? We just give them those enzymes. So pancreatic enzyme supplementations, they can be taken orally, and we should also supplement their vitamins to get them up to par with their vitamin levels if they have deficiencies. We should make sure that we have checked a B12 level on these patients, particularly also because they're alcoholics, and give them B12, supplemental B12 if that needs to be done. And so this is what the calcifications look like. This is an abdominal plain film here, and the way you can tell is that it just follows the path of the pancreas. The pancreas sits right behind the stomach. It's kind of attached to the stomach. It's a really sort of goopy organ, and it sits right behind the stomach. And so you can see it right here, right where the stomach would be. This is the pancreas right behind it, and these are the calcifications. And here you go, right here. On the left side of the patient, this is the left side. Here's your stomach right here. This is your pancreas here and your kidneys. So it's between the stomach and the kidneys. Okay, and these are all your calcifications. So some other causes, and these are much more rare. They're much less likely to come up on the test, but you should be aware of these because they do exist, and you should just know that they do cause malabsorption. So tropical sprue, the exact cause is unknown. It's likely that there's various causes. In this case, the patient will have lived or traveled to a tropical region. As far as tropical sprue, what I would be most aware of is to not jump to this diagnosis just because a patient has lived or traveled to a tropical region. A lot of us have gone to Brazil or to Mexico or to the Caribbean, and so you shouldn't make the jump to the conclusion that a patient that has lived or traveled to a tropical region has tropical sprue. Making the diagnosis of tropical sprue should follow once you've excluded celiac disease and pancreatitis. So once you've excluded those and the patient still has malabsorption, they still have fat in their diarrhea, go ahead and do a small bowel biopsy, and that will be diagnostic. You don't need to know what that small bowel biopsy looks like. Just know that that's the way you diagnose tropical sprue. And if it comes back positive for tropical sprue, then the treatment is going to be Bactrim, which is trimethoprim sulfamethoxazole, or doxycycline. Whipple's disease is exceedingly rare, but we do know what causes it. It's the pathogen known as Trophorema whippelli, and it does not require travel outside of the United States. It can be contracted here. However, it is extremely, extremely, extremely rare. So don't expect this. Again, these are not common causes. Whipple's disease is probably the least common cause of malabsorption. But again, this is going to be sort of a diagnosis that you come to once you've excluded everything else. The diagnosis for Whipple's disease is again going to be a small bowel biopsy, but what we do is we're going to take some of the biopsy to look at and some of the biopsy to do a PCR. And we can find the genetic material of the Trophorema whippelli, and that would be diagnostic. We can also look at the small bowel, and what it will show is PAS positive, periodic acid shift positive, foamy macrophages. And the reason I say this is because you don't need to know what it looks like on biopsy, but you do need to know the biopsy report. You will never need to look at a biopsy as a physician unless you want to be a pathologist. But as a physician, you should know what biopsy reports mean. So the treatment for Whipple's disease is going to be the same as for tropical sprue. You can use trimethoprim sulfamethoxazole or doxycycline. You can also use ceftriaxone for Whipple's disease.